Hello everybody and welcome to our module on rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder that involves inflammation of the joints, especially the hands and the wrists. Specifically, it involves what are called synovial joints. We'll talk more about those in a minute, but those are some of the more mobile joints in your body, like the hips, the knees, the hands, and the wrists. It's more common in women, as are most autoimmune disorders, and the usual age of onset is about 40 to 60 years old. And this is a picture of Lucille Ball. She was an actress, used to be on a TV show called I Love Lucy, and she supposedly had rheumatoid arthritis, and I always remember her as an example of the typical type of patient who has the disease. The pathophysiology of rheumatoid arthritis involves the synovium. The synovium, or the synovial layer, is a very thin layer of tissue, just a few cells thick, that lines joints and tendon sheaths in synovial joints in our body, and it secretes a substance called hyaluronic acid to lubricate the joint space. And because of this lubrication, the synovium is very important for highly mobile joints in our body. The pathophysiology of rheumatoid arthritis involves inflammation of the synovium. There's an unknown trigger, and there's overproduction of cytokines, especially TNF and IL-6. And you should remember TNF because, as we'll talk about later, many of the drugs used to treat rheumatoid arthritis are TNF blockers. When the synovium becomes inflamed, it can hypertrophy and it can thicken into a structure that is called a pannus. This is synovium that has been infiltrated with inflammatory cells and granulation tissue. There's a characteristic increase in synovial fluid, and the pannus can erode into the cartilage and bone and destroy the joint. As you will see later, there are antibodies produced in rheumatoid arthritis against proteins in the body, and these can circulate and deposit in joints and other tissues. Therefore, rheumatoid arthritis is an example of an antibody-mediated immunology process, and it's an example of a type 3 hypersensitivity reaction where circulating antibodies deposit in tissues and cause tissue damage. Here's a picture of a synovial joint. Two bones are coming together and they are covered by a cartilage called articular cartilage. And that cartilage is in contact with synovial fluid in the joint space, and this makes for a very slippery joint so that the joints can easily move. On the outside of the joint space is the thin layer of synovial cells, and this is the layer that hypertrophies due to inflammation in rheumatoid arthritis. When it thickens and hypertrophies, it's called a pannus, and it can eat down into the cartilage and bones, and it can destroy the joint space. Rheumatoid arthritis classically presents with symmetric joint inflammation, and the fact that it's symmetric is very important for distinguishing it from the more common type of arthritis, which is osteoarthritis. Patients with osteoarthritis typically develop symptoms in one joint on one side of the body at first. Later, the disease can progress and involve multiple joints on both sides of the body, but that's usually not the way it starts out. On the other hand, rheumatoid arthritis, because it's an autoimmune condition, usually begins with symmetric inflammation of the joints. The onset is gradual, and patients will notice pain and stiffness and swelling in the affected joints. Classically, they complain of what's called morning stiffness. This is joint stiffness that lasts more than 1 hour after rising, and this also helps to distinguish it from osteoarthritis. You can have morning stiffness in osteoarthritis as well, but it usually resolves in less than an hour. In addition, rheumatoid arthritis has symptoms in the joints that improve with use, and this also makes it different from osteoarthritis, where the more you use the joints, the more they hurt. And then finally, patients with rheumatoid arthritis often have systemic symptoms like fever that signal that there's inflammation occurring. You will never see systemic symptoms in patients with osteoarthritis. Classically, rheumatoid arthritis affects the MCP and PIP joints of the hands. There's a hand x-ray shown on the screen here. This is one of the MCP joints. This is one of the PIP joints. Importantly, the distal interphalangeal joints, or DIP joints, way out here on the fingers, are generally not affected. They are usually spared. And this is in contrast to osteoarthritis, where the DIP joints are often involved. The joints will be painful and tender to the touch, and if you look at this picture on the right side of the screen, this is a picture of a person with rheumatoid arthritis, and you can see there's redness in these joints in the middle of the hand here, and this is a classic way for rheumatoid arthritis to present, with signs like this on both sides of the body. If rheumatoid arthritis is left untreated, the bones of the hand and the wrist can begin to erode and deviate. And two classic findings in severe untreated rheumatoid arthritis related to this are ulnar deviation and swan neck deformity. Ulnar deviation refers to swelling of the MCP joints, which causes the fingers to deviate towards the ulnar side and the wrist to deviate towards the radial side. Here's a picture from Oh My Arthritis on the web, and you can see that the fingers are deviated towards the ulnar side and the wrist is sort of pushed in this direction over towards the radial side. That's ulnar deviation of the fingers, seen in severe rheumatoid arthritis. Second finding is the swan neck deformity. This occurs when there's hyperextension of the PIP joint and the DIP joint becomes flexed. The fingers begin to look like a swan's neck, like this man has here, where it sort of comes up and then goes out like this. Most people know that the hands can be involved in rheumatoid arthritis. A lot of students memorize that the MCP and PIP joints are classic, but you shouldn't forget that any synovial joint in the body can be involved in rheumatoid arthritis. So you can see involvement of the wrists, also of the elbows, you can see involvement of the knees and the hips, and then in addition, many rheumatoid arthritis patients have symptoms in their toes as well. It's very important that you appreciate that rheumatoid arthritis is a systemic disease. There are many symptoms that occur outside of the joints, and you don't want to think about it as just a joint disease. Especially when you take step one of the boards, board examiners are aware that many students memorize the joint findings, so they will often ask you about the systemic complications. So in the next few slides, I'll go through those. The first one you should know about is called a Baker cyst, which is also called a popliteal cyst. This is a cyst that occurs at the back of the knee in the popliteal fossa. There is a synovium-lined sac back there that can become swollen at the back of the knee. It's continuous with the joint space, and the patient can present with pain and swelling at the back of the knee, and that's a Baker cyst. If this Baker cyst ruptures, it will give the patient pain traveling down their leg, and this will often mimic a deep vein thrombosis. And in fact, one of the common causes for patients to present to the emergency room with symptoms of a DVT but then a negative Doppler ultrasound is because they had a ruptured Baker cyst. Patients with rheumatoid arthritis can develop inflammation of the serosa, and that usually means inflammation of either the pleura around the lungs or the pericardium around the heart. Pleuritis presents as pain on inspiration, and it can progress to cause a pleural effusion and symptoms of a pleural effusion. In the heart, symptoms of pericarditis can develop, and these can progress to become a pericardial effusion. Shown on the screen is the echocardiogram of a patient with a large pericardial effusion. This black space around the heart is the pericardial effusion. This is the left ventricle here. And I've shown you this picture just to help remind you that rheumatoid arthritis can lead to pericardial disease. Subcutaneous nodules, which are also sometimes called rheumatoid nodules, occur in many patients with rheumatoid arthritis. These are palpable nodules in the subcutaneous tissue of the skin. They happen to about 20 to 35% of patients. As we'll discuss later, some patients with rheumatoid arthritis are positive for the rheumatoid factor while others are negative. It turns out that the subcutaneous nodules generally only occur in people who are RF positive. It's very uncommon for them to occur in someone who is rheumatoid factor negative. They're common on the elbow, although they can occur anywhere, and the pathology consists of central necrosis surrounded by palisades of macrophages and lymphocytes. This is a picture of a biopsy slide here. You can see there's central necrosis in the middle, and there are these palisading lymphocytes and macrophages here surrounding the central area of necrosis. And usually they require no specific treatment other than treating rheumatoid arthritis in general. Occasionally they have to be removed surgically if they're very large. It's high yield to remember that rheumatoid arthritis can affect the eye in a number of different ways. Rheumatoid arthritis can cause episcleritis. This is inflammation of the episclera, which is the surface layer of the eye. This will lead to a red eye that is painful but usually does not have any discharge. A more serious eye condition is scleritis. This is a picture of scleritis on the screen here. This is often bilateral. The eyes are dark and red, and there's a deep, boring ocular pain when people try to move their eyes. The eye muscles insert into the sclera, so when you have scleritis, it hurts to move your eyes. And then finally, rheumatoid arthritis is also associated with uveitis. The uvea is the vascular layer of the eye. Symptoms are different depending on whether patients have anterior or posterior uveitis. If they have posterior uveitis, they'll get symptoms like floaters and vision loss. If they have anterior uveitis, the symptoms can look more like scleritis or episcleritis. While we're talking about eye symptoms of patients with rheumatoid arthritis, let me mention that many patients with rheumatoid arthritis develop secondary Sjogren's syndrome. I talk about Sjogren's syndrome in its own module, but for our purposes here, I'll just remind you that it's another autoimmune disease that involves damage to the salivary and lacrimal glands. The symptoms that develop are dry eyes and dry mouth. These are sometimes called sicca symptoms. The word sicca means dryness. And Sjogren's syndrome is commonly associated with rheumatoid arthritis. It's also commonly associated with lupus. Osteoporosis is a big problem for people, especially women who have rheumatoid arthritis. This is a picture of a woman with severe osteoporosis on the screen here. You can see how her spine is hunched over. Osteoporosis is accelerated by rheumatoid arthritis itself, and in addition, these patients often require steroid treatment, and that also worsens the osteoporosis. This is a very bad combination. Patients who have rheumatoid arthritis have a 30% increase in risk of having any major fracture and a 40% increased risk of having a hip fracture. Now let's talk about some of the antibody tests that can be used to diagnose rheumatoid arthritis. About 80% of patients with rheumatoid arthritis are positive for the rheumatoid factor antibody. This is an antibody that is directed against the Fc portion of IgG antibodies normally found in the body, and it's very high yield to remember that this is the target of the rheumatoid factor antibody. So patients who are positive for the rheumatoid factor antibody are said to have seropositive rheumatoid arthritis. And as I said before, this is about 80% of patients. The problem with the rheumatoid factor test is that it has poor specificity. It can be positive in a number of conditions other than rheumatoid arthritis. Patients with endocarditis can have a positive rheumatoid factor, same for patients with Hep B or C. You can also find rheumatoid factor antibodies in patients with Sjogren's or lupus. So depending on the population in which you use the test, you may find that it has a poor specificity. A better test that is more specific for rheumatoid arthritis is testing for antibodies directed against citrullinated peptides. This antibody test is a more specific marker for rheumatoid arthritis and is often used to confirm the diagnosis. So citrullinated peptides are peptides that have had citrulline added to them, so let's review what citrulline is. This is a picture of the urea cycle from our biochemistry modules, and this is the amino acid citrulline. It's an amino acid. It has an amino group and a carboxylic acid group, but it's a non-standard amino acid, meaning it is not encoded for by our genome. Because it's not encoded by our genome, citrulline cannot be incorporated into proteins via transcription. However, it can be incorporated into proteins via post-translational modification of protein structures that have been derived from our genome, and it turns out there's more incorporation into proteins in the setting of inflammation, especially in rheumatoid arthritis. As a result, anti-citrulline peptide antibodies can occur, and in fact they're elevated in up to 80% of patients with rheumatoid arthritis, and this is a much more specific antibody test than the rheumatoid factor, and it can be used to confirm presence of the disease. Other laboratory findings of rheumatoid arthritis include an elevated C-reactive protein level and an increased erythrocyte sedimentation rate. These are nonspecific markers of inflammation, and you can find them elevated in many autoimmune diseases. And then finally, there's a strong association of rheumatoid arthritis with the HLA-DR4 serotype. I talk in more detail about the different HLA serotypes in the immunology module on transplants. For a long time, the treatment of rheumatoid arthritis was NSAIDs and steroids. My grandfather had rheumatoid arthritis, and he used to take NSAIDs every day, and he used to take steroids every once in a while when his symptoms flared. And we always knew when he did this because he would start talking all the time. Nowadays, there are multiple new treatments that you can use, and these are called disease-modifying anti-rheumatic drugs, or DMARDs. The reason they're called disease-modifying is because they've been shown in clinical trials to protect joints from joint destruction. These include drugs like methotrexate and azathioprine and cyclosporin and hydroxychloroquine, and I won't talk about these 4 drugs now, but I do discuss them in the immunology module on immunosuppressants. 3 drugs which I will discuss in this module are sulfasalazine, luflanomide, and the TNF-alpha inhibitors, which are antibodies against TNF-alpha. This is the structure of sulfasalazine shown on the screen here. If you take it by mouth, your colonic bacteria will split the structure into sulfapyridine and another molecule called 5-aminosalicylic acid, or 5-ASA. You may know that aspirin is acetylsalicylic acid, so 5-ASA and aspirin are very similar structures. And in fact, 5-ASA has a very similar effect to aspirin. It can be used as an anti-inflammatory drug. 5-ASA is sometimes given by itself. It's a drug called mesalamine, but if you give it as sulfasalazine, as people do in rheumatoid arthritis, it will be split by the colonic bacteria into the active form 5-ASA. Leflunomide is a very rarely used immunosuppressant. Its 2 niches are rheumatoid arthritis and psoriatic arthritis. Leflunomide inhibits an enzyme called dihydroorate dehydrogenase. This enzyme is responsible for converting dihydroorotic acid into orotic acid. In the biochemistry modules on pyrimidine synthesis, I talk about how orotic acid can be used to synthesize uridine monophosphate, and from uridine you can derive cytidine and thymidine. So if you blunt the synthesis of orotic acid, you blunt the synthesis of nucleotides. As a result, there is less DNA and RNA synthesis, and this will have its greatest impact on rapidly dividing cells, which include cells of the immune system. As a result, this will act as an immunosuppressant. Its main side effects are nonspecific features like diarrhea, abnormal LFTs, and low white blood cells, and that's because you have inhibited DNA and RNA synthesis. Infliximab is an antibody against TNF-alpha, and it's used in the treatment of rheumatoid arthritis and also in Crohn's disease. One of the greatest dangers posed to people who take this drug is reactivation tuberculosis, and in fact PPD screening is recommended prior to treatment, and they like to ask you about this on your board exams. In addition, patients who take infliximab are at risk for other infections, including bacterial infections, especially pneumonia, and they can also get reactivation of herpes zoster while they're on this drug. Infliximab is one drug in a class of drugs called TNF-alpha inhibitors. Other drugs in this class include adalimumab and golimumab. These are both monoclonal antibodies to TNF-alpha. And then a final drug in this class, which has a unique mechanism, is etanercept. This is a recombinant protein of the TNF receptor, so it looks just like the TNF receptor, and it functions as a decoy, so it will bind to tumor necrosis factor instead of allowing tumor necrosis factor to bind to the actual receptor. When it binds to etanercept, it has no effect, and therefore it decreases the activity of TNF-alpha. I'll finish this module by talking about a couple of the long-term complications of rheumatoid arthritis. Earlier I mentioned that women with this condition can develop osteoporosis. There is also an increased risk of coronary disease. This is true of rheumatoid arthritis and other autoimmune diseases, especially lupus. It's believed that the inflammation can lead to plaque buildup in the walls, and coronary disease is the leading cause of mortality among people with rheumatoid arthritis. Another long-term complication is secondary amyloidosis. Amyloidosis occurs when you get amyloid deposits in the kidneys and in other tissues. There can be a primary amyloidosis, which is a plasma cell dyscrasia, but you can also get amyloidosis secondary to autoimmune diseases, and rheumatoid arthritis is one of the classic conditions to cause secondary amyloidosis. This is a picture of a biopsy showing the apple-green birefringence of amyloid to remind you that amyloidosis can occur secondarily to rheumatoid arthritis. I'll finish this module by discussing Felty syndrome. This is a rare complication of rheumatoid arthritis that occurs in a small percentage of patients. It consists of a triad of rheumatoid arthritis plus splenomegaly and neutropenia, and it classically occurs in someone who's had rheumatoid arthritis for many years and who has severe disease, including joints that are deformed and lots of extra joint involvement. There's no specific therapy for it, and it usually improves with rheumatoid arthritis treatment. And that concludes our module on rheumatoid arthritis.